I now pass the floor to Professor Bruno Lina, virologist, who will talk us during 15 minutes about the virus itself. Professor Lina, you have the floor.
Thank you very much. So I'll try to share my screen. Okay, I hope you can see the screen.
Okay.
Good. So I will try to let you know a little bit of what we know about SARS-CoV-2. Actually, we have some already things that we know, but you have to keep in mind there's a lot of unknown that are remaining now. But I will try to touch as much as possible the current knowledge about the virus, about how we can do the diagnosis, what are the different issues regarding transmission, and hopefully I will try to address most of what you have as questions. I have a slide regarding my conflict of interest, but I don't have conflict of interest on that topic specifically. So this virus has been actually emerging from China and maybe from Wuhan, but maybe other places in China as well. And very early, we could first of all see the virus and then have the sequence of the virus, which really helped us very much to identify what is the causative agent of the disease that we observed, unlike what was observed during the first SARS epidemic in 2003. So during this new epidemic, we knew from the very beginning what was the virus, as you can see here in electronic microscopy on cell lines, and also what was the sequence of the virus. And according to the sequence data that we have, and these sequences, as you may know, are shared in the GIZET platform, we identified that the virus that was detected from cases was very close to one of a bat virus precursor, and very close from another virus that was detected in the pangolin, which is supposed to be the animal responsible for the spreading of the virus from the bat to the humans. That was the intermediate host that helped for the transmission of the virus. That is what we think. And from the beginning of the virus, when it emerged, we identified, first of all, that these viruses were very closely related to one and each other when we have cases, although some cases were detected in different regions of the world. You can see from France, from Taiwan, from Singapore, from USA. That was very early in the time, in February. All these sequences were very, very close. And when we also analyzed what was the virus in terms of comparison with the other viruses, this beta coronavirus is somehow quite closely related to the SARS coronavirus that emerged in 2003, with significant differences, as you could see here. This is the spike protein, which is the protein which is at the surface of the virus. And this protein is interacting with the receptor, which is ACE2. And you can see that this virus, these two proteins from the SARS and from the new virus were having some similarity, but some differences. And amongst the similarities was the fact that it was binding to the same receptor to the cell. So that helped us to understand the biology of the virus. The second thing is that with the diffusion of the virus at worldwide diffusion, we identified genogroups within that virus according to what we call the G, V, and S genogroups. These groups just reflect some genetic diversity, but they do not reflect any difference in terms of transmissibility, in terms of severity, or in terms of antigenicity. All these viruses, although they have been classified in genogroup, have very common and similar features. And with the time being, as you could see, it was the end of April. We have now more than 20,000 full genomes that have been sequenced. And you can see that the G genogroup is the main virus which is circulating, and it is mainly observed in the USA, Northern America, and in Europe. and also in China. But there's a trend of having this G group becoming larger and larger. Although, like I said before, it doesn't mean that this virus has specific features that makes him different as compared to the S or the V genomes. So in terms of clinical impact, what has been recently published, it's a study coming from France, but it is very robust in terms of descriptions of the cases. What we have seen is two important things. First of all, males are more frequently having severe disease as compared to women. Although the rate of transmission between males and females are not different, when you look at the number of people admitted to the hospital, or when you look at the number of people that are having very severe disease leading to death, you could see that every time, especially for the older age, males are more frequently encountered as compared to the women. And the second thing is that when you have with an age that is below 50, it is very rare occurrence that you are hospitalized or that you are having severe cases. So you have to keep in mind that if you're older than 60 and if you're a man, you're more exposed to have a severe infection, and you're more prone to be leading to admission to ICU cases and eventually death for some of the cases. And this is very strongly seen in the over 80s. When you look at the diagnosis of this infection, what we have seen is that this infection, first of all, is unlike what has been seen in 2003, the virus is replicating very well in the upper respiratory tract. So the key diagnosis is done by doing swabs, nasopharyngeal swabs, and to collect specimens from upper respiratory tract, and using PCR that could be designed very early in the time because the sequence was available. This technique is very sensible, and it is described to be able to identify more than 90% of the infected cases. The second step of the infection often occurs in the lower respiratory tract, and I will show you the timelines of the different events. And we know that it occurs by the 6 or 10 days after infection. And again, if you collect a respiratory sample, you can have a positive PCR. But what has been seen also is that doing CT scans in these patients when they're having lower respiratory tract symptoms, you can have some more or less specific ground glass opacities that could be helpful to identify cases sometimes when the upper respiratory tract was negative. What we have seen also is that the stool can be positive in terms of detection of RNA, but there's still some discussion whether the stool could be infectious or non-infectious, because most of the attempts to cultivate the virus from stool specimen has failed. And we know now, and I will touch a little bit on that, that we have some good and robust serology that is emerging now, and we can have some ideas of what is the time lab of the apparition of the IgG, IgM, and the immune response. What is not known yet is the sustainability and the duration of this immune response, but this is because of the fact that this is an emerging virus for which we don't have much time behind us. So when you look at the PCR, different sets of PCR have been proposed by WHO, and this is something that was produced from my lab. And that we see is that these PCR that are proposed are more often very sensitive, and they can detect up to 10 to the 8th in terms of dilution of the virus, which means a couple of less than 100 virus in a specimen. And some of the PCR, especially those that have been developed by the Institut Pasteur in France, has been shown to be one of the most sensitive of the PCR. But these PCR are very helpful, and they can detect, like I said, the specimens the virus in the clinical specimens up to less than 100 virus per specimen. So when you look at the very first cases that we identified in France, that was cases that were admitted to the hospital in Paris, and this is something we published in Lancet Infectious Disease. What is interesting in these cases is that in 5 cases, it was more or less summarizing all the cases that we have seen all over the time. The first one is the very mild cases when you have viruses that were detected very early during the disease. It was peaking in the early days of the disease, and by day 9, there was a complete disparition of the virus, and the patient was completely healed. So that was a mild cases. It was admitted to the hospital because at that time we admitted all cases to the hospital to prevent transmission. The second one we have is the dark green one, which was more severe cases when we could see a more prolonged shedding of the virus up to, it was detected up to 16 days after the disease onset. But these cases had something peculiar, is that it was positive in the upper respiratory tract and then became negative, but it became positive in the lower respiratory tract when it was developing a lower respiratory tract infection. So, and that was where the positivity of the specimen was sustained a little bit longer as compared to the mild cases. And the third kind of cases were the more severe cases, where we could see that these guys were absolutely not getting rid of the virus. The virus could be detected up to 24 days after disease onset, and it was correlating with severity. And in these cases, what we also see is that it was positive in the blood in a significant manner. I mean, the CT was pretty low, whereas for all the other mild cases, it was not possible to detect the virus in the blood. We could detect the virus from 2 out of 5 of these cases in the stool, and this was absolutely not correlated with the severity. We could not detect the virus from the urine. The urine remained always negative, and 2 of these patients had conjunctivitis, and we collected the specimens, and all were negative. And these patients developed a pleural effusion, and during this pleural effusion, there was 1 sample that was collected, and the virus was detected in the pleural effusion, which means that with all these 5 cases, more or less, you had the picture of what you could see in terms of evolution on the disease for the early diseases. I will not touch the late disease. Based on the experience that we have, and this is a cohort of patients that we are following in France. It's called the French COVID cohort. What we could see is that based on the different samples that have been collected in more than 200 cases, and the monitoring of the CT values and the viral load that we had in these patients, what we see is that there's a global trend of reduction of the viral load along with the disease, although some have sometimes viruses that could be at higher titers during the disease because of clinical presentation, but the global trend is a reduction. And when you normalize this, you can say that, first of all, there's no big difference between the severe cases, which are in red, and the mild cases in blue. So you cannot predict based on the CT values or based on the viral load you have in a clinical specimen, whether this is a severe or a non-severe cases. The trend of evolution of the virus remains very similar between the two, but still you know that some of these patients may have a viral expression that could last longer than 14 days. And when you try to normalize this, on average, the mild cases are supposed to be excreting virus up to less than 20 days, whereas the more severe cases can have, in average, a virus shedding that can last a little bit more than 20 days. And you can see that when you look at the percentage of people that are infected with the disease and that have become negative, it's very unlikely to have a negative result in the PCR before the 7th days of the disease. But then when you're by day 21, only half of the patients are negative, and you have to wait for more than 28 days to see more than 80% of people becoming negative. And you could see that the negativity tends to become to arrive earlier in the mild cases in blue as compared to the severe cases in red. There's also some knowledge about the immune response. I will be very short on that because there's a specific topic on that, but you have to keep in mind, this is something that has been published by the group in Pasteur. What you could see is that based on different kind of kits you may use, techniques you may use, and based on the target, which is either the spike protein or the nuclear protein, or the technique that you may use, the detection of the seroconversion and the antibodies can be significantly different. If you look at this ELISA N here for this green patient, you can see that he is positive by day 5, whereas you use the spike protein with another techniques, the positivity can be seen very much later. But that was not the case with another technique. So you have, when you interpret the data, you have from the serology, you really need to know what is the capacity of the test you're using to interpret properly the results. But based on all this information we have, we can more or less say that all the cases that have been investigated here, we detect antibodies very early in time by day 5 to day 7. And when you look at the percentages of neutralization capacity of these antibodies, you can see that by day 21, and maybe by day 14, most of the patients that have this antibody response have actually neutralizing antibody. Whether these neutralizing antibody are sustainable, this is unknown yet, and we have to work on that.
Professor Lina,
but we also see.
May I ask you to conclude, please?
Yeah, I thought I have 2 minutes late. Okay. So based on the, what is interesting also is to see that in the severe cases, sometimes there's a lack of immune response, and we have identified one case where the interferon alpha response was very low, and this resulted in a very large and in a very rare severe cases, as compared to those that were having a good interferon alpha response. We could also see that you can monitor the patients based on the evolution of very simple markers like hemoglobin, white blood cells count, and urea in the blood, where when you have severe cases, it drops to the, when you have somebody that becomes severe, it drops to the severe presentation and the severe patterns of the patients. And in terms of diagnosis, and I will finish with that, I think you have to keep in mind that diagnosis really relates according to the expression of the virus and the appearance of the antibodies. So this timeline here is reporting what happens in an individual. You can detect the virus by PCR before the incubation, before the end of the incubation period, and before the disease onset. This way of detecting can be done by sampling the upper respiratory tract, and also the lower respiratory tract by day 6 when they become severe cases, either requiring ICU or O2 supplementation. This positivity can last longer than only a couple of days, and it lasts longer, more than 30 days, like I said, in severe cases. And what we have also seen is that in terms of serology, the more severe cases are seroconverting earlier than the mild cases, and the asymptomatic cases cease to be seroconverting much later than the mild and severe cases. So I will not touch on the dissemination, and I will just go to the acknowledgement of the people that are working in my lab on that subject. Thank you very much.
Many, many thanks, Professor Lina, for this excellent and very informative presentation, which surely will generate a lot of questions. Many thanks. And many thanks for keeping the time.